Welcome to part one of our lecture on gender dysphoria, sexual dysfunction, and paraphilic disorders. In this lecture, we will define key terms such as sex versus gender and review the diagnostic criteria for gender dysphoria in children, adolescents, and adults. Key terms: sex. Sex is biologically based indicators of being male or female, such as genitalia and sex chromosomes. Interestingly, all embryos are identical for the first 8 weeks of gestation. During the prenatal production, male hormones produce male development, and an absence of male hormones produces female development. This will be very important later when we think about why might someone have a gender identity that's inconsistent with their biological sex. Gender is socially constructed notions of what it means to be more or less masculine or feminine. Biological sex is not the same as gender identification or the embodiment of female masculinity or femininity. Some wonder if gender and sex still matter in today's society, but sex determines virtually every facet of our lives, even before conception, and certainly by the time we are an embryo. Studies show that people interpret the same gestational behaviors very differently if they know or believe that an embryo is male or female. For example, if there is a flutter and the person knows that the embryo is male, they may interpret that as, oh, that was a really strong kick, this one's going to be a football player. But they don't have that same reaction if they believe that the embryo is female. And if you still don't believe that this is an important factor even before birth, think about when a child is born or if someone's pregnant. One of the first things we ask is about the child's sex. Was it a boy or a girl? We ask that before we even find out, are all parties healthy? Another important term is gender assignment. This is also referred to as natal gender. This is the initial assignment as male or female, and it's usually based on the prominent biological sex characteristics at birth, meaning their genitalia. Gender dysphoria refers to the subjective distress that might accompany the incongruence between one's experienced or expressed gender and one's assigned gender at birth. This can also be a diagnosable condition as well, which we will be discussing in greater detail. When the difference between one's expressed or experienced gender and their assigned sex is extreme, when this lasts for over 6 months, then gender dysphoria may actually be a diagnosable condition. So this would include examples of a male, biological male, feeling that he's really a woman. In the past, this has been called transsexualism, then moved to the term gender identity disorder, and now the appropriate terminology is gender dysphoria. Here we see a strong and persistent cross-gender identification, so it's not merely a desire for some of the cultural advantages of the other sex. This is a deep-seated feeling that their body is incorrectly identifying them as male or female, and that they truly identify as a different gender. Discomfort with their assigned sex, being distressed with their assigned natal gender or sex, and a significant distress or impairment as a result. For example, there may be an adolescent male being teased about effeminate behavior. Someone might experience social isolation. These would all count as distress or impairment. When looking at gender dysphoria in children, we require at least 6 of the following symptoms. 1, a strong desire to be or an insistence that they are of the other gender. Cross-dressing, having a strong preference for attire that's atypical of his or her assigned gender. For example, a girl that wants to wear clothes that are more typically assigned to boys. Strong persistence or preferences for cross-gender roles when playing or when engaging in fantasy play. Strong preference for toys, games, activities that are stereotypically used or engaged in by the other gender. Strong preference for friends of the other gender. rejection or avoidance of toys, games, and activities that are stereotypically used or engaged in by their own assigned gender. And we would also evaluate whether or not they had a strong desire for the primary or secondary sex characteristics of the desired gender. So whether they wish that they could have or change their genitalia to match their desired gender. We add the specifiers of with a disorder of sex development. This occurs when there are congenital conditions in which their development of chromosomal, gonadal, or anatomical sex is atypical. In simpler terms, this would have been those individuals in the past that we would have defined as hermaphrodite or intersexed. In essence, these are individuals that are born with ambiguous genitalia or non-standard genitalia. Most people don't realize that this is actually very, very common. 1 in 100 children are born with non-standard genitalia. In our class of 300 students, this would mean that there would be 2 to 3 people that had been born with ambiguous genitalia. In the past, physically intersexed individuals could not receive the diagnosis of gender dysphoria. The DSM-5 changes now allows individuals to have gender dysphoria and to have been born intersex because we realize there actually could be things that make them related. This is also important because it's only recently have we allowed infants that have been born with ambiguous genitalia to get older before doing any of the surgeries to make their genitalia more standard. In the past, they would use things to make a determination early on and perform a surgery on a newborn infant to correct their genitalia. And sometimes those corrections might actually be wrong. It didn't match with their desired gender. So the standard now is to encourage parents to allow their child to develop until their desired gender becomes more clear, and then, if needed, perform any of the surgeries to create a more standard genitalia. I'm going to show you a video from the movie Middle Sexes: Redefining He, She. This is a wonderful documentary. I highly encourage everyone to take some time and watch the entire documentary. The information is mind-blowing, and for many people, information that they had not had an opportunity to know in the past. Here I'm going to show you about 6 minutes of a video about a young child with gender dysphoria.
In the heartland of the American Midwest, 8-year-old Noah is already a boy apart.
Midwest America is a real difficult place for a child like Noah. We have a lot of farmers, hardworking people that have always grown up that a boy's a boy and a girl's a girl, and it's also a strong religious belief that Noah shouldn't be like that because God didn't make him that way. It's hard to make people understand.
I like to make stuff out of like ribbons and stuff, like shirts and skirts and stuff like that.
I know it's nothing that we've done. Noah has been that way since he's been old enough to express himself. We've done many things to try to steer Noah away from the way he is now. Nothing's been encouraging. I think with a child like Noah, if you accept him unconditionally, you're teaching him love. You're teaching him that his parents love him and they support him, no matter if he's different than the other boys. And I do know one thing, he didn't choose to be like this.
You put it like this, put it in the back, then you twist it in the back, hold on like that, put it up here and tie it.
Were you worried about this?
Yeah, I was very worried about Noah. I didn't want him growing up, being liking girl stuff or whatever, thinking he was a girl. Nobody wants their son to grow up like that.
And you gotta keep on wrapping it around until there's nothing left of it. And then you've gotta tuck it in so it stays. Then you have a skirt.
It would be very much relief if Noah, when his hormones kicked in, that he just started acting like the rest of the boys. It would be a relief to me, because I know the main thing, his life would be a heck of a lot easier.
Noah's mother, Michelle, and her present husband, Mike.
Did I not give you two?
Noah's older brother, Luke, a boy like any other boy. For the sake of the children, the adults agreed to put their differences behind them and build a relationship that would make the boys feel equally at home in either household, their fathers or their mothers. Not the only decision that makes this family special.
We don't know a single other family that deals with these issues. We're working it all out ourselves, and then when I have my family that's saying, the family I was raised in, that's saying you're doing it wrong, and I feel so much in my heart that I'm doing it right, sometimes it's overwhelming.
Why do your family think you're doing the wrong thing?
We're a Christian family, and that's what the Bible teaches literally, specifically. I think in Deuteronomy it says that men are not to wear women's clothing. In Genesis it says God made a man and a woman so that they might procreate. This is exactly what it says. No matter what was written in the Bible or any historical document, I can't believe in a God who would not love my Noah for exactly the way he is.
I hope that he will be grounded enough in who he is to be able to withstand that and just be himself and say, I am who I am. You're the one that has the problem. He gets teased, boys and even girls come up and ask him, are you a girl? And they'll call him, names, slur names that you hear, and he gets it at school quite a bit.
Are the children ever unkind to you?
Not usually. Usually they're just asking me questions.
Like what?
Like, are those girl shoes, or are you wearing girl shoes? And they just ask me questions like that, like about my clothing and stuff.
When you start being called a lesbian, homo, fag, when you get called a he, she, the question I think that bothers them the most now is, are you a boy or a girl?
I would just like to tell people that I don't feel like answering all those questions, so don't ask me.
What are your greatest fears?
Just that someone will hurt him. I've read it more than once, that there's about a 50% chance that these children will be killed or kill themselves. That would be my biggest concern.
I want to draw your attention to just a couple of pieces that were brought up in that segment of the video. One, the parents describing the fact that this clearly is not a choice for this child, that this is a part of his being. This has been a way he has expressed himself since he was first able to do so. And also encourage you to think about the idea of choice when we talk about gender identity, and that this begins so very early on, and they experience such heavy stigma. Really becomes unreasonable to assume that this is merely a choice for people. It's a clear part of who they are, and they are driven to have authenticity, to be who they are naturally, and this discussion about choice really is a false discussion. Other thing that was important to note was their discussion of the fact that one of their single largest fears is that he would be driven to commit suicide or would be killed or hurt by someone else. And that is a very real fear, because the rates of violence against children and adults with gender dysphoria are significant. When looking at gender dysphoria in adults and adolescents, we are looking for at least two of the following symptoms: a marked incongruence between one's experienced or expressed gender and the primary or secondary sex characteristics that they have. This can also, for adolescents, be the anticipation of the secondary sex characteristics that they will develop as they continue through puberty. So this would be that extreme distress and the experience of their physical body not matching their perceived gender. 2, a strong desire to be rid of one's primary and or secondary sex characteristics because of the incongruence between their experienced gender and their physical body. Or again, in adolescence, a desire to prevent the development of those anticipated secondary sex characteristics, and a strong desire for the primary and or secondary sex characteristics of the other gender. A strong desire to be of the other gender or some alternative gender different from their assigned sex, assigned gender at birth. A strong desire to be treated as the other gender or some alternative gender different from one's assigned gender. And a strong conviction that one has the typical feelings and reactions of the other gender. Again, we would add specifiers. We would add the specifier of with a disorder of sex development. Again, that would be similar to what we talked about with children, where they were born with ambiguous or non-standard genitalia. We would also add the specifier post-transition for those individuals that have transitioned to full-time living in their desired gender. This can be with or without actually pursuing a legalized gender change. And they have undergone or is preparing to have at least one cross-sex medical procedure or treatment regimen. This might be regularly taking a hormone treatment to align their body with their desired gender, or having gender confirmation surgery to help their body transition to their desired gender. This might be like a vaginoplasty in a natal male, mastectomy. They have undergone some process to align their body with their desired gender, and they have been living full-time in their desired gender. I'm going to show another couple of segments from the same video, Middle Sexes Redefining He and She. The first video is going to talk a bit about brain development and that it's consistent with the desired sex rather than the natal assigned sex, and that prenatal exposure to hormones cause development of sex characteristics regardless of our genes, which again counters the idea that this is a choice and emphasizes the biological nature of the condition.
Unlike Max Beck, most of us are recognizably male or female within 3 months of conception. Over the next 6 months, hormones sculpt the brain, male or female, but the genitals can develop in one direction, the brain in another. The Dutch Institute of Brain Research. Here they are looking for underlying biological explanations for differences in sexual identity and orientation. Deep within the center of the brain, Dutch scientists found differences between male and female, heterosexual and homosexual. They then turned their attention to the transsexual brain.
He found in the brains of male to female transsexuals a female structure, and in the brain of female to male a male structure. So this explains that the brains of these transsexuals have not developed in agreement with their genitalia. They have all the characteristics of one sex, genetics, gonads, genitalia, hormones, but the brain has not followed that track.
These differences were discovered in clusters of nerve cells so tiny that no scanner could detect them, let alone measure them. The only way they could be studied was by microscopic examination of tiny slivers harvested from the brains of the dead. The Dutch research has made a huge contribution in helping to secure the rights of transsexuals under European law. To our Western thinking, if it's choice, it's the wrong choice and should be corrected. But if it's biology, it's fixed and must be respected. But one question remains unanswered. When did those brain changes occur? Because life's experiences and life's choices also shape the brain, which starts to respond and change long before we are born.
When you're in there, you're experiencing different circumstances, coldness and heat, and the noises that you hear when you're in the embryo. You'll actually hear things, and you'll probably remember some of them. And then when you're born, it isn't all over. Your brain is only half formed at that time. Anyone who's seen a tiny baby knows that this baby has a lot of growing to do.
Humans are born with very incompletely developed brains. Huge numbers of neural connections are made after birth, which means as a response to, in conversation with their environment and their experience. Even at the age of 5, children don't necessarily think their sex is fixed. Children still believe, until surprisingly late, I think, that it could change, that today they're a girl, but they might be something else tomorrow.
And then you grow up. You got this body, it works, life is wonderful. Then puberty hits. Breasts develop, testes start secreting androgens again and making sperm. Your ovaries start to make eggs. Now we're talking about another critical period in which what you experience becomes crystallized in your brain as part of who you are. So for example, if you have a crush on, say, your gym teacher, and you're 13 and he's maybe 19, and you have a sexual experience with this individual. Well, is that sexual experience going to mean nothing? The experiences, I think, are absolutely key to understanding things like sexual orientation, and not only sexual orientation in terms of gay, straight, bi, but sexual orientation in terms of what you like, what you're attracted to.
Unquestionably, the majority identify as male or female and are attracted to the opposite sex. But with so many potential turning points on the road to sexual maturity, all humanity can't be expected to conform to this single standard. A more likely outcome is a huge variety of sexual identities and preferences.
And there are as many sexual orientations as there are faces. Because sexual orientation isn't only whether you're gay or straight or transgendered or other, and the fifth other. It's what you like, it's what you do, how often you do it, and with whom, and and to make it straight or gay is ridiculous. To make it straight bi or gay is less ridiculous. To make it straight bi, gay, transgendered is even less ridiculous. But you can imagine how far does that go?
The whole world is not white, male, heterosexual, white, female, heterosexual. We live in a glorious world of endowments, and that is true socially, and it's true sexually.
One thing we have to remember, from Darwin to Kinsey to any great thinker about sexuality, is variation is the norm. Biology loves variation. Biology loves differences. Society hates it.
Some interesting things to consider with the video is the fact that when they look at individuals' brains post-mortem, they now can see that their brain development is more consistent with individuals' desired gender versus their assigned sex at birth, and that hormones are driving the development of our sex characteristics, which means that if something goes wrong in that process, an individual could have been genetically predisposed to develop as male, but their body then develops as female, and vice versa. There's so many different questions that this brings up, but it also really goes back to that question of, is there choice in this or not? And it looks like a significant proportion of this is biologically driven. As the video noted, the prevalence of gender dysphoria at diagnosable levels is very, very rare. About 1 in 37,000 males and 1 in 150,000 females. When we look at sex differences in the rates of referrals to specialty clinics, they do vary when you look at different age groups. So for children, natal boys to girls, meaning they were born and their assigned sex was male, but their desired gender is to be a girl. This is anywhere from a 2-to-1 ratio to a 4.5-to-1 ratio for children. Among adolescents, the rates even out to natal boys to girls being about 1-to-1. But then again, for adults, the data ranges from some estimating there's a 1-to-1 equal ratio, and others finding that natal boys are 6 times the rates of natal girls. But it's important to note that not all adults seeking hormone treatment or surgical reassignment end up at a specialty clinic. So these rates are likely modest underestimates. And as we saw with Noah, the age of onset is very, very young, typically 2 to 4 years old. This does not mean that that's where they're diagnosed or where they first sought treatment, but when people are able to say when their symptoms of gender dysphoria first began, or when others report on when they noticed some differences with their child, typically it began between ages 2 to 4. Studies have also examined the percentage of those with gender dysphoria that persist into adulthood and find that this persistence is modestly correlated with the severity of the dysphoria that they had in childhood. So among natal boys with gender dysphoria, estimates range anywhere from 2.2% to 30% will persist into adulthood. And for natal girls, the estimates range from 12% to 50% will persist to adulthood. Which does bring up the question of, such a very small number continue to have symptoms or they deny them. So what's going on there? Why does that seem to be happening? And we know that there are parental and peer influences. So they are receiving a lot of pressure to kind of get back into their gender box and to enact gender in a way that is consistent with their assigned sex. Sexual orientation and sexuality also appears to influence that persistence. 75% of the boys who did not continue their gender dysphoria into adulthood determined that they were actually gay or bisexual, and the remaining quarter later identified as heterosexual. And for treatment, there are psychosocial treatment options as well as biological treatment options. The appropriate term for surgeries that address this are gender confirmation surgery. It was formerly called sex reassignment surgery, but gender confirmation is the appropriate term at this point. Approximately 1 in 30,000 males and 1 in 100,000 females seek these operations. It is very, very difficult to qualify to have gender confirmation surgery. For example, there's very strict criteria. Often you have to be evaluated by 2 separate trained professionals that specialize in gender dysphoria. Often you have to have lived a full 2 years, although I have seen some guidelines that have said 1 year, but living full-time, all day, every day, as their desired gender 100% of the time, and a variety of other requirements before individuals can qualify to have gender confirmation surgery. So it's not something that happens lightly. It is something that is spaced over a considerable period of time. People often work for years before they can qualify to have the procedures done. After surgery, 75% have a significant improvement in how they feel about themselves and how they feel about their bodies. Female to men tend to be more satisfied with the changes than male to female. And 7% regret having had the surgery. Interestingly, a significant portion of that 7% tend to be natal males who had surgeries to align their body as female. And part of that regret is seeing that the privilege they had as males goes away as they are now treated as females. Psychosocially, the goals for treatment are really going to vary according to what that individual wants. So some of the treatment may be helping the individual feel more comfortable in their assigned sex. If they do not, for whatever reason, want to pursue gender confirmation surgery or any of these procedures, they want to be comfortable in their assigned sex, there may be treatment helping them to develop that comfort. They could have a possible secondary goal of trying to change arousal patterns if they're desired, so trying to generate more masculine sexual fantasies as an example. There could be efforts to teach the individual how to act in a way that is more stereotypic for their assigned sex. There could be efforts to teach them vocally how to communicate in ways that are more consistent with their desired gender. But perhaps one of the biggest things that would be the focus of the focus of therapy is helping them to cope with the way they are treated by others. You recall from the video with Noah, 50% of those with gender dysphoria have at least one suicide attempt by age 20. Suicide rates prior to having gender confirmation surgery are 31%. Those are successful suicides. They have died by suicide. 75% of them are victims of hate crimes. So there's considerable trauma they may need to deal with. There's a lot of work that needs to be done just in coping with mistreatment. This brings us to the end of our first section on gender dysphoria. In section 2, we will begin to talk about sexual dysfunction.